Hello, and a very good evening, ladies and gentlemen. This is your host, Dr. Aditi Nanda, warmly welcoming you to today's webinar. Our guest today is a true enthusiast and a leading implantologist. With more than 18 years of successful clinical expertise, this gentleman puts no limits to what he can achieve in life. He is a senior consultant at SPS Apollo Hospital from the last 8 years and has now started to extend his services in the Fortis chains as well. He's a fellow, International Congress of Oral Implantologists and Academy for Oral Implantology, both of which are two of the most prestigious and eminent organizations for implantologists in India and across the world. He has been honored by the Indian Dental Oscars with the Outstanding Dentist Award of the Year 2021. The more I say, the less it is. He has been the guest speaker for various national and international conferences and has numerous scientific research papers to his credit. He pursued an advanced course in dental implants from Israel and is currently the proud owner and runner of Dr. Grover's Dental Implant Center, Ludhiana. Ladies and gentlemen, this is not it. Our guest today is currently pursuing his Masters of Dental Surgery after nearly 2 decades of a flourishing dental practice. It gives me immense pleasure to welcome and introduce our eminent speaker for today, Dr. Parminder Singh Grover. Sir, I, on the behalf of entire team of Dentist Channel, welcome you on board with us. Thank you for joining with us today, sir.
Thank you so much, Aditi. You've spoken too much about me. I don't think even मैं छोटा सा भी हूँ वैसे. Otherwise, it's all God's grace and my family support that these things have been achieved. You yourself are doing very well for DentistChannel.Online and Sinodent.
Thank you so much, sir. It was a pleasure to introduce you.
Yeah. So not wasting much time, I guess we should start.
Yes, sir. So before that, we would like you to put some insights to today's topic, that is immediate implant placement post-extraction.
Yeah. I started with implantology over around 10 years back, 10 to 12 years back. And the basic protocol that we know was brain marks protocol, as we all know that he's father of implantology. So it was like waiting for 3 to 6 months after extraction, asking the patient to come again. The patient might forget, patient might not come to get an implant. So, and also where I'm located in Ludhiana, where we have a lot of NRIs coming here, and they have like 30 days, 20 days time, and in which you have to give the implant. They have to attend their weddings, they have to sell a property, they have we have to place implant and give provisionals. So we had to change, we had to modify. It is said, as Einstein very well says, necessity is the mother of all inventions. So this was also like, it was a necessity to go and do immediate implants. So I started around 7 years, 8 years back that I started placing immediate implants, and now we are really pro in it. And we place, usually the patient comes and asks for an implant, we have autoclaved kit ready, and we immediately say, oh, why not, let's place an immediate implant. So, but all said and done, I have now gained experience and I'm confident that I can do all this. But I would advise those who are starting their implantology never to try immediately, because you should always have a right CBCT or an X-ray or diagnostic tools before you start doing all this. So once you are a pro in regular implantology, then this is kind of an advanced implantology, and then you can go ahead and do these kind of things. So in advanced implantology, you have to have those diagnostic tools with you. Also, you have to have a good knowledge of anatomy of the vital structures that they are there. So people are afraid of placing implants in why? Because of these anatomical structures like the maxillary sinus or the inferior alveolar nerve. So if you have all these knowledge and you are experienced, so it is a 2 minutes job. Placing an implant is a 2 minutes job. Aditi, even you can place an implant. It's not a big deal.
With your help, definitely, sir.
So there are a lot of students around India who have had training from me. And one thing I always say to my students, one life is going to change with my webinar or my workshop. And I've hopefully, with God's grace, I have changed many lives. and my students are now visiting consultants at various clinics.
Wow, that's
So,
amazing.
so they are increasing the benchmark, and they are, you can say it is not a race though, but I'm really proud as a mentor to see them really jumping off and climbing the steps slowly, steadily. But yes, they are really passionate about it. One thing, Diti, what I say is you have to be really passionate about the thing you do. So if you have that passion and you have that will to do, nothing is impossible in world.
It's an honor to have you here, sir. You have already, ignited that spark in us before we begin. Thank you so much. I'm definitely eager to go ahead with the webinar.
So I'll
So
be.
before we begin, our viewers must know that they can put in any queries that they might have in the Q&A box given below. They'll all be addressed in the end by the master himself. Thank you, sir. We are good to go.
So I'll be sharing.
Yes, sir.
Are you able to see my screen?
Yes, sir. It's visible.
So as today being Mahashivratri, so blessings to all with the blessings of Shivji. Let all be the best implantologists, do a lot of implantology and have great osseointegration.
Indeed, sir.
So this is a small video. This is what, welcome to Dr. Grover's world of implantology. This is what Dr. Grover is doing right now. We have a full mouth rehab. You are going to see this pre-opics patient having terrible, you can see the terrible RPTs that he's having, and you can see the condition of the teeth. They are periodontally really compromised, and we had to extract it and place implants then and there only. This is how the osteotomy began. You can see the spade drill. You can see the osteotomy being done. There are various drills that are used in implantology. These are the alpha bio implants that I'm placing, and you can see we were doing the full mouth. We did the maxillary, mandibular in one day, and you can see the torque that I was getting. It was 35 to 40. The patient is around 55 years old, but you can see the parallelism that is maintained with the drills, and these are the implants. So we did a case of 4 implants, 4 in the maxillary, and 4 in the mandibular. Now see, love and enjoy the change of profile. Look at him. Look at where the proclined anteriors went. Look at him. He's so happy. He regularly visits now he's referring some cases to me also. Picture abhi baki nahi hai mere dost. Picture abhi shuru hui hai. That's what Dr. Grover is all about. So hi, she has introduced me already, so I won't take much time. Yes, I'm a consultant implantologist. I visit clinics also. I give workshops also. So there is a slight sneak peek into what I do regularly. These are some of the pictures of ICUI. I took ICUI fellowship. It is the oldest and the most reputed fellowship to be taken around the world, around more than 100. You can see the delegates that are come to take this ICUI fellowship. More than 100 countries are proud to have this ICUI coming over to them. And this is some of the press releases that happened when I went to ICUI. I'm also fellow for Academy for Oral Implantology. You can see Dr. Lankamesh is one of the pioneers of implantology in India. This is the most reputed implantology organization in India. Now, I did an advanced course in Israel in 2016, soft and hard tissue to deal with soft and hard tissues in the mouth. And these are some of the really good picks around there. I am also outstanding dentist for India, got this award in 2021 from FamDent. And just a sneak peek, quickly, I'll be moving on to the topic, which is today immediate implant placement. I'm really passionate about it. In my free time, I write articles in newspapers as well. These are few of the articles that I've wrote for dental implants. These were published in Times of India. This is Wall of Fame in my clinic. I'm really proud of. Hopefully, I'll be increasing these certificates more in the coming time. These are some of the awards I've achieved, though the figure has gone much more now. This was like picture was clicked 2 years back. So these are some of the courses that we mentor. We do immediate implant placement, we do sinus lifts, we do graftings, we do all the advanced courses and also the basic. This guy, you can see he has an old 35-year-old practice and he is still learning implantology. That's what I say is passionate. You should be passionate about the work. So we did around 20 surgeries in this. This is some of the courses going on in my clinic, lectures going on in my clinic. And these are some of the talks that I've been doing for dental implants. These are the initial days when it started. Now you can see this is a guy everyone must be knowing. Dr. Aditi you must be knowing, this is #1 aesthetic dentist of India. So he visited
Dr.
my
Sandesh
clinic.
Mankar.
Yes, he's given smile designing to many celebrities of Bollywood, Hollywood, everyone. So he visited my clinic. He gave a few tips to me, and which I've been inculcating into practice and reaping the dividends. So this is what I say: implant nahi kiya to kuch nahi kiya. So why do I say such things? Implant nahi kiya to kuch nahi kiya. Because it involves the main 5 branches of dentistry. #1, oral surgery. Placing an implant is a surgical process. Periodontics, taking care of the soft and the hard tissue, the gums, and also the bone, involves periodontology. Prosthetics, placing a crown over it into occlusion, is prosthetics. Oral radiology, learning about CBCT and OPG, is radiology, and the RBG. You have to have precise, accurate reading of these uh, radio tools that you have with you. Oral medicine, knowing about the higher antibiotics like the meropenem and the linzolids. These kind of antibiotics usually you don't go in your regular practices. These only come in handy when you are doing the higher surgeries. Why are we afraid of doing implants? Basic knowledge of anatomical structures is missing. We don't know the anatomical structures like the path of the inferior alveolar nerve and also the maxillary sinus. What the poor diagnosis, we don't go for initial impressions, we don't take bites. If we are doing a full mouth, it is a must that you take primary impressions for a model, then take a bite, then understand what the prosthetics is going to be. It is a costly, complicated armamentarium with the kind of revenue that it generates. It's not at all. And I sure when people come to me, I have that formula of placing an implant with only 3 drills. So it is as easy as that. Patient doctor fear of surgery, yes, patient is fearful of surgery, but even a tooth extraction is a surgical process. So it is much easier than extracting a tooth. Lack of convincing power, yes, slowly, steadily, you will know how to convince patients to getting implants. So why dental implants? As you can see, it is very close to the original tooth. You can see it, the root is simulating to the implant, and only difference is the PDL fibers here. The composition of implant, one must know. It is mostly everyone will be knowing that it is made up of titanium, but some of you must not be knowing that it also has aluminum, vanadium, iron, and oxygen. So every component has different roles. It's not that it's only titanium. We also have zirconium implants also. So what are the properties of titanium? Why titanium is universally accepted as a metal for implants? It's #1, it's biocompatible, it's non-reactive, ability to resist corrosion, it is non-corroding. The oxygen comes in handy here, it forms TiO2 to resist corrosion. And high ion strength, that is basically because of vanadium, inherent ability to osseointegrate. Finally, low modulus of elasticity near to bone, so that the stresses are dissipated into the basal bone. Dude, where were you when we needed you? These are the abutments, the vital abutments saying to the implant. So the implant has finally arrived, and arrived in a big way. So the future is digital dentistry and implantology. So make sure you inculcate implantology into your practice as soon as possible. Otherwise, you're going to lag behind. So topic for today, immediate implant placement after tooth extraction. So to know about immediate implant placement, we must know what original protocol for Brainmark was. Brainmark is, everyone knows, he is the father of implantology. So it needed 3 to 6 months of healing post extraction. We used to extract, wait for 3 months. If it's a atraumatic extraction, if it's a traumatic extraction, then we had to wait for 6 months. Placing a titanium in a 2-stage surgical, then we had to wait for the prosthetics. 3 to 6 months again for osseointegration to take place after we have placed the implant. So we wait for 3 to 6 months to implant to osseointegrate. And finally, it used to take around 1 year to complete the whole process, and patient would get irritated, yaar, ye kya ho raha hai mere sath? So why? As I said, he is the famous man. I guess everyone knows this face. This is Einstein, and Einstein used to say necessity is the mother of all invention. हमें जरूरत हुई तो हमने implant place किया immediately. So these are some of the articles on the net, and there is evidence that immediate implant placement is far better than a delayed implant placement. I have reasons for it. It is evidence based. I'm not saying it, it is evidence based. So guys, start putting implants immediately after tooth extraction. Number one, why we want to place immediately implants, why it is better than a delayed implant placement. It prevents alveolar ridge atrophy. It is said that alveolar ridge resorbs immediately in first 6 weeks. It is like 2/3 of the resorption happens in initial 6 weeks. Fewer visits to dentist, as I said, surgery after extraction, immediately implant is placed. Obviously, you are cutting down on 3 to 4 months. And if you are giving the provisionals, patient is so happy. And if he's an NRI, he's so happy to get an teeth immediately on that day only. Chances of placing implant along the same axis is more, yes, because you have extracted it and you can see the socket. Like you can kind of drill 1 or 2 drills and you are ready to place an implant. So your precision basically is more here. Immediate aesthetics can be restored in all on 4 cases, or all on 6 cases. We give provisionals immediately. So the patient comes with no teeth and goes out with around 20 teeth or 22 teeth or 24 teeth. So where we can place now? The question arises, can we place immediate implants in every situation? No, it's not that like that. There are certain conditions where we can place, and there are certain limitations to it also. So we should be prudent enough to know where we can place. Residual roots like this. These residual roots can be extracted if it is a passive infection, there is no active infection, and you can find enough sound bone beneath these root stumps or residual roots. High chances you can place an implant. Root fractures, like the fracture in the middle third, like you can see, if there's fracture, you take out the crown and the root portion separately, and you can place the implant here. If you do it atraumatically, the condition is you have to do everything atraumatically. The more bone you get, the more chances of osseointegration is. Periodontally compromised teeth, like this one. So these are periodontally compromised teeth. You can see the status of the mouth. You can see unhealthy gingiva. They are to be excised and removed along with the tooth, and all the granulomatous tissue is removed, curetaged, and then you can place an implant after copious irrigation with saline. People do it with chlorhexidine. People do it with clindamycin and other things. I basically prefer saline only, normal saline. And then we place an implants and then suture it out. Grossly decayed teeth like this, you have enough bone apically, and you have good interradicular bone, as you can see. So you extract it, section it midway, and extract the 2 roots, and then use this interradicular bone to place the implant. Non-restorable fracture tooth. So if you have this 3 or 4 wall defect, you have only 1 wall standing, you know that you can't place a crown, you can't restore it, you have to extract it. There is no choice. So when you extract it, you have great socket, you can place an implant immediately, then and there only. So where you cannot, so these are the areas where you cannot. I'll show you with slide by slide. These are the conditions where you cannot place an immediate implant. Number one, signs of active infection or there is a discharge. Number two, there is an extraction socket where has large osseous defect. That means 3 or 4 wall defect. Inadequate bone volume, you don't have enough bone, 3 to 5 millimeters is not bone, the vital structures are nearby, you can't place an immediate implant. There is an inadequate thick stable keratinized margin gingiva. That is very important, though we don't take it seriously, but a thick stable keratinized marginal gingiva is very important for hermetic seal, number one, to avoid periimplantitis, number two, and to give aesthetics, good aesthetics, number three. Signs of active infection or purulent discharge, like this slide, you can see the slide. There is a lot of infection periapically, and you can see, if you can see discharge in the mouth, this is not the place to, obviously you have to extract the tooth, but this is not the place. You just curettage the area and you can place graft and suture it out. But an implant failure, high chances of an implant failure is here. Extraction sockets, which has large osseous defect, we have a chart for it. The initial 3 socket with 5 bony walls, 4, 3, you can place an implant with peri-implant socket grafting and also with grafting with the tent screws, or we can say the with bone tags, and you put a membrane over it and then you suture it out. But when you have this socket with only 2 bony walls or socket with only 1 bony wall left, then you are not going to place an implant then and there. What you do is you place a block graft there to maintain this hard tissue, and then you put a membrane over it or a mesh over it, and then you suture it out. Wait for 4 to 6 months, that is 2 to 3 months, 4 to 6 months, and then come back again, and then just see, take a CT or an X-ray or an OPG just to see whether the bone has been formed. CT is a better choice. You get a 3-dimensional picture. If it's fine, then you place an implant. Most probably after 4 to 6 months, you get very good bone. Inadequate thick stable keratinized gingiva, the condition will be like this. So you can see unhealthy gingiva, and there is free and mobile gingiva, and is non-keratinized. So why it is important? Keratinized attached gingiva, how it look like? It has a lot of hemidesmosomes, is healthy, is pink in nature, and the collagen fibers are perpendicular to the implant surface. So कोई loose gingiva, ढीला gingiva नहीं होगा. So वो tightly implant को दो सारी तरफ से पकड़ लेगा, so that there is no plaque accumulation between the gingiva and the implant. So if there is no plaque, there is no chances or food lodgement, there is no chances of peri-implantitis. So this you have to make sure that the condition is this when you are placing an implant or you are loading it. So always try submerging the implant 1 to 2 millimeters below. What protocols or guidelines to follow? Number one, reading of CBCT is must. You have to take care whether we have 3 to 5 millimeters of bone or not. When we are near maxillary sinus, we have to take care that where is the Schneiderian membrane, where is the floor of the sinus. If you are going for indirect or direct sinus lift, we can place an implant immediately. We can graft apically, but we have to make sure as to how much we are going into the sinus. So I've been doing it. I've been extracting. I've been raising the flap and doing direct sinus lifts and placing the graft in the sinus and through the crest also, and placing an implant over it. And we are getting very good results also. But it is a time-taking process, and also with experience only you gain. You will fail multiple times. You fail, then you realize what your mistakes, and then you start slowly gaining in confidence, and then you really get good results for it. Healthy bone below the socket should be 3 to 5 millimeters, as I've been telling all through. Preferably, socket should have all the walls intact, preferably, but we can go till 2 to 3 wall defects. Still, if you get the right torque, that is like 30 Newton centimeter plus, you can always place an implant. Density of bone should be D1 or D2. What is a D1 or a D2 bone? This we will understand from this chart, which is given by Mish. So the Mish has given this chart. When you do a CBCT and you move your cursor around, you will get to know what density of bone is there. So if we have a D1 bone, it is greater than 1250 Hounsfield units. If it's D2, then it is between 850 to 1250. Rest you can see D3, D4, D5. Normally D5 we don't find. D3 and D4 are in upper sevens. Maxillary. Chances are high that we find in maxillary or in those patients like female patients who have crossed their menopause and they are like very old. Relative contraindications. So these are some of the relative contraindications. You have to see whether you can place an implant or not immediately. Patient on chemotherapy or compromised immune system, like patient on anti-cancer drugs. पेशेंट जिनके हार्ट वेल्व रिप्लेस हुए हैं, जिन्होंने बाईपास किए हैं या स्टंट पड़े हैं, within 1 year they are on 2-3 blood thinners. So try avoiding placing immediate implants on those. Patient on biphosphonates or steroids, because healing jaldi nahi hogi, osseointegration nahi hogi. That's why even in chain smokers it is same. Schizophrenic or patient with the habit of bruxism, you don't basically give provisionals, because bruxism mein wo forces lagengi and wo aapke jo crowns hain wo bhi tutenge, and basically there will be damage to the hard bone as well, bundle bone as well. So the failure of implant is high in these cases. So going on to the implant design, what should be the implant design when we go for this immediate implant placement? The implant design should be the widest and the longest. जितना भी आपका स्टॉक है उठाओ, उसको खोलो, सबसे बड़ा 16 mm का इम्प्लांट, चौड़ा 5 mm का इम्प्लांट, 6 mm का इम्प्लांट. यू हैव दैट. नॉर्मली मोलर्स में हम बड़े इम्प्लांट से लेते हैं, इट्स लाइक 4.5 or 5. And the size is not 16 though, because we have inferior alveolar canal running there, but around maximum जितना आप ले सकते हो. तो so it, because आपका जो नीचे वाला 3 to 5 millimeters है वही मैकेनिकल लॉक होना है initially. There is no osseointegration, so there is no bone coronally in the middle third. There is hardly any bone. Interradicular bone आप साइड में डाल सकते हैं या grafting करोगे, but the natural bone that there is available, that is like 3 to 5 millimeters apical to the socket. So वही वाली आपने engage करनी है. So that's why it is the longest possible implant. Active implant with deeper threads with high pitch value to engage maximum bone. So आपके जो threads होते हैं, it should be active. Noble active you can place. I've been placing semi-active because now universal designs come. So still, if you have this noble active or an SPI implant which have deeper threads, we can engage and lock mechanically the bone. They are much better. Using implant with osseointegration surfaces like the SLA or the anodized surface, sandblast and acid etched. Implant platform should be platform switch. अब सारे ही implant platform switch आते हैं. पहले सारे implant platform match आते थे, अब सब प्लेटफॉर्म स्विच है. दैट मीन्स कोई भी कंपोनेंट जो अटैच होगा इम्प्लांट में वो इम्प्लांट के अंदर होगा और इम्प्लांट के ऊपर उसका डायमीटर छोटा होगा इम्प्लांट के डायमीटर से. सो इम्प्लांट के डायमीटर से छोटा होगा तो जो स्ट्रेसेस होंगी वो आपकी क्रिस्टल बोन पे नहीं जाती. सो दैट इज व्हाट एन इम्प्लांट प्लेटफॉर्म स्विच इज. इमीडिएट इम्प्लांट प्लेसमेंट इन अपर इंटीरियर्स, दिस इज हाउ यू डू. आप दांत निकालते हो, बट आपने जो इम्प्लांट डालना है वो पैलेटल कॉर्टेक्स के बिल्कुल साथ में डालना है, away from the buccal bone, which is said to be very fragile. So अगर आप गलती से भी आपका path change हो गया and you are towards the buccal bone fractures. So you have to take care कि it is like engage the palatal cortex and then parallel it and then place the implant. And if the jumping distance is more than 2, then you have to graft it. Jumping distance is between the implant and the buccal cortex. So for upper interior, use a pala drill or a ligament drill. Keep it towards hard palatal cortex, reaching 3 to 5 millimeter below the extraction socket. Implant जो होगा, जो आप drill last करोगे, उससे जो implant होगा, osteotomy जो करोगे, उससे implant 1 या 2 diameter बड़ा होगा. If you are doing osteotomy with 3 millimeters, you place an implant with 4 millimeters. Graft the buccal cortex area of the socket. अगर आपका jumping distance 2 millimeter से more होगा, तो आपको वो graft करना है. And as I said, submerging the implant 1 to 2 millimeters below the crest of the socket. it should be 2 to 3 millimeters below the cemento enamel junction of the adjacent tooth. Adjacent tooth के cemento enamel junction से 2 to 3 millimeters का फायदा ये होता है कि you get a nice aesthetics with the gingiva, and it gives really good aesthetics. So basically इसका purpose aesthetics है. Try having bicortical engagement of the implant wherever possible. So bicortical engagement means if we have a nasal floor, I'll engage my implant and anterior implant into the nasal floor. Reverse torque value is always important than torque value. Reverse torque value तब काम आती है when we check the osseointegration. अब आपकी torque value 35-40 न्यूटन सेंटीमीटर, reverse torque अगर आपकी 30 न्यूटन सेंटीमीटर आती है, so you can immediately do with the provisionals. So this is criteria for giving provisionals immediately. For posterior teeth, use a spade rail in center of the roots. It is the clinician's or the implantologist's choice कि आपने जो आपकी इंटररेटिकुलर बोन है उसको पहले आपने ट्रेफिनेशन बर से बाहर निकाल देना है और यू एंगेज दिस इंटररेटिकुलर बोन एंड प्लेस इट. व्हाट आई डू इज, अगर तो बहुत थिन है तो मैं रिमूव कर देता हूँ, आई यूज इट एज अ ग्राफ्ट. बट अगर वो थोड़ी थिक है तो आई ट्राई एंगेजिंग इट, गेट मैक्सिमम कॉन्टैक्ट विद द इंटररेटिकुलर बोन along with the apical 3 to 5 millimeters of bone, whatever is available. Loading classification for immediately inserted implant. So this is the conventional loading. The implant is loaded after 3 to 6 months. That is what we do. Early loading is implant is restored in occlusion after 48 hours of insertion and before 4 months have elapsed. ये हम तब करते हैं जब all on 4 all on 6 देते हैं, पेशेंट आस्क फॉर प्रोविजनल तब हम देते हैं. नॉर्मली हमें अर्ली लोडिंग तब करनी चाहिए जब हमारे पास मल्टीपल इम्प्लांट्स हो. Now single implant में if it is anterior you have to de-occlude it so that it doesn't come into occlusion. Otherwise there are high chances कि आपकी crestal bone loss होगा या आपका implant fail हो जाएगा. So it's better that you give these implants, splint the implants together and then give these provisionals. Delayed loading, again after 3 to 6 months you have grafted the socket. It is a 2 to 3 wall defect, bony defect. They have grafted the socket and then you give delayed implant because all you are not getting the right amount of torque. Like you are getting a torque of 20 to 25 newton centimeters. Then you submerge the implant, उसके ऊपर कवर स्क्रू लगा दो और उसको suture कर दो और फिर अगेन जो रेगुलर है डिलेड लोडिंग 3 to 6 के मंथ्स के बाद ओपन करो एंड उसके ऊपर फिर आप क्राउन लगा दो. Progressive loading is light contact at first. You get a very good torque. The bone is D1, D2, and you get a 40 Newton centimeter torque. The reverse torque is also very good. You can give light, and you have multiple implants. You can give a light contact at first and then gradual load it to full occlusion. So what is the consensus on immediate loading? It is a universal consensus. आपका implant कम से कम 10 मिलीमीटर से ज्यादा होना चाहिए. इम्प्लांट डायमीटर 3.3 मिलीमीटर से ज्यादा होना चाहिए. आपका जो डिजाइन इम्प्लांट का हो वो स्क्रू फॉर्म या टेपर्ड हो सो दैट इट एंगेजेस योर एपिकल. जो हमने 3 to 5 मिलीमीटर बोन बोली है वो एपिकली अच्छी तरह एंगेज कर ले, लॉक कर ले. एंड इम्प्लांट सरफेस रफ होनी चाहिए सो दैट इट attracts the bone towards it and osseointegration आपकी फास्ट हो जाए. occlusal scheme में no occlusal और lateral forces होनी चाहिए. So वही ब्रक्सिजर और ये वाले केसेस में आप अवॉइड करें. So आपकी occlusal forces minimal होनी चाहिए. Classification and descriptive terms for the timing of implant placement after tooth extraction. So this is a chart I would like everyone to see. So if immediate implant placement, the desired clinical situation should be post-extraction site with no healing of bone or soft tissue. So I'll again go on to the chart. This is the chart I am looking and talking about type 2, type 3, and type 4. After this chart, I'll be showing you my cases also. So type 2 early placement with soft tissue healing, it is typically from 1 to 2 months, and post-extraction site with healed soft tissues and without significant bone healing. This is what you see. That is what desired is. Type 3, early placement with partial bone healing. It is typically from like 1.5 to 2 months, and post-extraction site is with healed soft tissues and with significant bone healing. Normally, when I go for a full mouth rehab, normally I take a CBCT after 1.5 to 2 months to see kitni bone ban gayi hai and what is the density of the bone. And after 3 to 4 months, when I'm trying to start loading the final processes, then again I ask the patient to go for a CBCT and see how much osseointegration has taken place. If it's sufficient, then we start loading it. Now, a few of my cases. Before I end, this is patient Mrs. Amarjeet Kaur, aged 55 years, reported to the clinic for replacement of 1-1 and immediate extraction and placement of implant using socket shield technique. We used a socket shield technique. Socket shield technique, again, we should have a different lecture for this. It's a very good technique that is being used in upper anteriors or others also. I'm using in anterior still canines. So the patient on examination was diabetic and on blood thinners. We did it. We do various cases. There was no allergic history though. The implant that I placed was pivot 3.7 into 16 millimeters. You can see the length that I placed. It is more than 3.3, and you can see the length that I placed. This is how the patient turned up to the clinic. These are pre-op pictures. ऊपर का सब कुछ उसका टूट गया था and only a root was there. So what you do in a socket shield, you preserve the buccal side of the tooth, the coronal part of the buccal tooth, and then you section it midway. So this was the section that was done, and you can see long shank burrs are used in this, and you take the palatal side because you're going to place into the palatal cortex, the implant into the palatal cortex, and your buccal cortex is preserved. This is the implant we place. This is the graft we are doing. The peri-implant spaces of the socket has to be filled with the graft. You can't leave it like that. And then you suture it out. If there is a primary closure with the gingiva, you suture it out like that. If it's not there, then you use a collagenous resorbable membrane over it, and then you suture it out. Look at the length of the implant. It is 16 mm. So I engaged 3 to 5 millimeters of bone, and it's doing very well. You can see the final processes. That was the final crown that was given. Now the next case, quite a difficult case because of various reasons. Old patient, finicky patient, and you can see at least A1C. So 3 months sugar profile said 8 to 9%. Many doctors had refused her before she came to my clinic. I took advice of an endocrinologist in SPS Apollo. That is what I'm blessed with. So endocrinologist maintained her sugar level to around 180 to 212. It was really fluctuating. It used to go to around 12% as well. So we maintained it around 8 to 9%, and I placed the implants immediately after extracting. And the patient was 65 years old. See, I'm using an ostem here. You can see the various sizes. This was an all-on-4 case. So these were the root stumps, and these were the mutilated tooth. They were present in the mouth. I extracted all in one go. And this is the guide you use for all-on-4. So place the guide for the angulated implants and the straight implants. So you can see the torque that I'm getting. Wonderful bone. These are the grafts that were done in the peri-implant sockets, and over it, and membrane was placed and it was sutured. This is the final processes that was given. You can see the final processes that was given. So she is looking very happy. Hopefully she is doing good. She comes to my clinic, and hopefully she's giving me good blessings for what I've done. Another case, Mrs. Seema, age 48 years, 46 years, came to the clinic with fractured 1-3, again using a socket shield technique to preserve the buccal bone. No known allergic history, no medical history. Implant, what I used is Alpha Bio Hair, 4.2 into 16 millimeters. You can again see the length of the implants that I'm using. That is the patient's profile, the front and the side. This was the fractured root that was present there. And you can see that I preserved the buccal part. This is what we are doing, the sectioning the root and doing socket shield. And then the osteotomy. When socket shield was done, we had preserved the buccal part. Osteotomy was done. The osteotomy drill was taken inside, taken an X-ray to see everything is fine. This is the implant that we placed and grafted it. Asked the patient to come after 3 months. The healing abutment is in place then and there only. And this is the final crown. This is another case. He came. He's a very interesting case. So I thought that he must have come for an RPD. He came with us on a cycle. So the patient was a labor, and I said कि यार cycle पे आया है, इसका दांत निकाल के पता नहीं ये दांत replace भी कराता है कि नहीं. But he went for an implant. So basically, what we do in our clinic is we don't see the economic economic condition of the patient. We tell all the probabilities. If the patient is intellect enough, he'll go for the best one. So we don't compromise on our treatment plans when a patient comes seeing his or her economic condition. So he was a young guy. And this is what the implant I placed. It is 4.2 into 11.5. This is the person himself. And that is the fractured root that it has. You can see only we had 3 mm of bone, 3 to 4 millimeters of bone that was left beneath. And that is sometimes I directly do with a spade drill so that I find the path of my final osteotomy, and then I take out the root stumps. This is the implant I placed. You can see the Schneiderian membrane. It is just inside the sinus membrane, and used all the bone that was available, and really minimally grafted it because he had a lovely immunity, and the osseointegration went very well. He came back. I thought whether he'll come back or not, but he came back. He got his healing abutment attached. Those were the impression copings that was placed to take the final impressions. And that is the final crown. You see, we gave a screw retained pre-cemented crown here and wonderfully placed. You can see the condition now. The interior, you can see the premolar 1/4 is also decayed, but he never came back for this. But obviously, I know that he's eating wonderfully well with that molar. Patient Gurmeet Singh, aged 62 years, reported to the clinic for replacement of 4-5. No allergic history. He's a great guy, an engineer by profession. Implant name and size is pivot 4.2 into 13 millimeters. He's a very intellect patient. This is front profile and the side profile. And this is the fractured root that was present there. The RCT was done by me only. So now the tooth had mutilated and fractured and was very weak. So we both planned that it has to be extracted and an implant is to be placed. So that is the implant that was placed, and we gave the provisionals immediately. So look at the torque that we get in a 55-year-old. So these are the bones, the D1, D2 bones that we are looking forward for placing a direct immediate implant. The healing cap was given immediately. And this is that X-ray with the healing cap and grafted. And this is the final processes that is given. And we gave the final processes quite early. It is kind of an early loading. Pre-cemented screw retained again. You can see the final crown in place, and look at the occlusion. Give a ZOA over it so that if any problem is there, we can always recheck it. Don't give composite immediately. Don't close the hole with composite, though composite can also be removed. And preferably always give not a cemented, but a screw retained prosthesis. The provisional has to be a screw retained prosthesis over immediate implant placement. Thank you so much for having me here. That completes my today's lecture. Aditi had given me 40 minutes, and I think I am 3 to 5 minutes above 40 minutes.
It's all
Hopefully,
right, sir.
Dr. Aditi will be happy with my effort.
Definitely, sir. I had no record of the time. I'm
So I was
being very
keeping a record
honest.
of the time, and I kept a record of the slides also, because basically now when you start speaking at various platforms, you know the slides are going to how much time the slides are going to take. So she had given me 45 minutes, and I am going and 40 minutes, and I completed in 44 minutes, I guess.
Right, definitely, sir. You definitely maintained that spark throughout the webinar, and it was indeed a very thorough and comprehensive coverage of the topic, even in 40 minutes, sir. And apart from the clinical tips, the major take home from this message that we are all getting is the motivation to keep climbing the ladder and to try to be better with each rising sun. Thank you so much, sir. It was a privilege to learn from you and in such a well documented way. Thank you so
Thank,
much.
thank you so much, Aditi, for having me here. There was a surprise announcement that we were promoting, and the surprise, should I now open the surprise now?
Definitely, sir. Definitely. I think it's time.
So before that, these are some of the, if you can listen to this audio, I don't know whether the audio will work.
Krishna Banerjee. I am from West Bengal, Murshidabad, and I came here to Chandigarh for learning the implantology. And Dr. Grover is awesome. He taught very well, and the way he taught is very good. And they the pivot implant is so good that because in the low cost margin we can deal the cost, and in the low cost margin we can to implant to the patient, and it is so affordable to the patient. So I choose the pivot implantology, and you also choose pivot implantology. Goodbye.
So this is the second student,
Right. What is the name, sir? He
Doctor.
mentioned
This doctor?
no,
No, no,
not the
no.
doctor's name, sir. He mentioned academy's name or something.
No. He mentioned a system called Pivot system.
Okay, okay.
So he had come basically for a basic course in Pivot. So he was mentioning the name of that company, the Pivot company. So it is low cost Pivot company that has good implants. I'm a keynote speaker for Pivot implants.
That's great, sir.
So
Both your
this is
patients
the,
and your students are blessed to have you.
yeah, thank you so much for that. And this is what I was saying about our surprise. Our surprise, we are going to have a live patient workshop on 5th of March, morning 10 to 1 on Sunday. So I'll be showing you my implantology skills on an immediate implant placement after tooth extraction. Before that, I'll be dealing with all your questions, and also we'll be doing implantology and showing you direct implants over dummy mandibles. So implant placement after tooth extraction, first on dummy mandibles, then we'll go and do it on a live patient. So that is what was the surprise all about.
It was so fun. We truly enjoyed this webinar, and what better than a workshop? So thank you so much for organizing this with us. And we are really looking forward to it, sir.
Yeah, and those who attend this workshop, I'll be giving free support, free guidance for the further 6 months. And also we'll be briefing about grafting, which grafting to do, which not to do. And also some are ready to take their new kits or want to get some advice from me. They are most welcome to go ahead and do that.
It's definitely a golden opportunity, sir. Thank you so much once again.
Thank you, Aditi, for having me here. I'm so thankful to Dentist Channel Online for having me here. I really thoroughly enjoyed this webinar too.
The honor is ours, sir. So there are a couple questions that I would like to discuss. So what is the role of TiO2 in osseointegration?
They form titanium oxide, forms a layer that prevents its corrosion. So so that it doesn't corrode, it has a titanium oxide layer over it. TiO2, it's said.
Okay, it prevents the corrosion.
Yes.
And sir, you also mentioned somewhere that implants with periodontally compromised gingiva, we can place immediate implants.
Yes.
So doesn't that risk for peri-implantitis?
No, you have to, what you have to do, you have to be very accurate in that. You remove all the unhealthy gingiva, all the reddish free papilla that is there. You remove all that, scrape it down, and then you remove all the granulomatous tissue and remove all your teeth. Then if you have really fine bone there, then you can always place an implant. So I've been doing it and regularly doing it, and we are getting very good result. If you've seen my first case, that was a video, he had really terrible oral hygiene. But once you convince the patient and he takes care of his oral hygiene, then nothing is impossible. So he is doing wonderfully well. We gave a hybrid denture to him, and he's doing very well, and he comes visits my clinic every 2 to 3 years. Now it's been 4 5 years that's it's been done, and he's the implants are working well, the denture is working well.
Okay. Answer a similar question. Like the jumping distance we talked about, should, if it's greater than 2, then we have to place in bone grafts.
Yes.
But what if it's like between 1 or 2?
Then you
Doesn't that
don't
again risk for peri-implantitis since we have a space there?
No, if you have like right tight primary closure, then there is no issues. If you have that primary closures, tight suturing, you should understand how suturing is done. So there should be another class for suturing. I'll tell you how to suture. So if you have that primary closure intact, there is no chance of anything seeping in or seeping out. So if you have that jumping distance of 1 millimeter around, you don't need to graft.
Okay, that's great, sir.
And also,
one another. Yes,
yeah,
sir.
yeah. If you need to graft, there are scrapers. So you scrape the autogenous bone only from surrounding. So उसके जो छोटे से fibrils आते हैं वही आप वहाँ पे intact कर सकते हैं. There is no need to use a big magnanimous कोई graft, right?
This is all increasing our interest for the workshop, sir. There is one more question, I think, but this one will better learn with the workshop. The difference between platform switch and platform match.
Platform switch में आपको हिंदी में easy भाषा में समझाऊं?
Definitely, sir.
कोई भी कंपोनेंट, चाहे वो अबटमेंट है, चाहे वो उसकी इंप्रेशन कोपिंग है, चाहे कास्टेबल अबटमेंट है, चाहे स्ट्रेट अबटमेंट है, एंगल्ड अबटमेंट है, कोई भी जो अटैचमेंट आएगी वो इम्प्लांट के डायमीटर के अंदर आएगी. लाइक इम्प्लांट के डायमीटर के अंदर आएगी. It will kind an act of it is called like a male component, and the implant is called like a female component, and gets inside only. So प्लेटफॉर्म मैच में ये होता है, जो उनके प्लेटफॉर्म्स होते हैं, सो वो बिल्कुल उनके डायमीटर्स बराबर के होते हैं. सो वो आपस में मैच करते हैं प्लेटफॉर्म्स, राइट. जब प्लेटफॉर्म्स पूरे मैच करते हैं, व्हेन यू हैव दोस व्हेन यू स्टार्ट द पेशेंट स्टार्ट्स ईटिंग, सो देयर मैस्टिकेटरी फोर्सेस. मैस्टिकेटरी फोर्सेस क्या करते हैं, वो सारे स्ट्रेसेस उस जॉइंट पे आते हैं. तो वो जॉइंट नॉर्मली आप 1 मिलीमीटर सबमर्ज करते हो, बट देयर इज अ क्रिस्टल बोन अराउंड. सो उस स्ट्रेसेस वो सारे क्रिस्टल बोन को डिसिपेट होते हैं. सो अगर डिसिपेट होंगे क्रिस्टल बोन में, तो वो क्रिस्टल बोन रिजॉर्प्शन होगी. जब हम उसको प्लेटफॉर्म कहते स्विच करते हैं, तो आपका जो स्ट्रेसेस होंगे वो सारे इम्प्लांट ले रहा है, इम्प्लांट की बॉडी ले रही है. तो वो सारे स्ट्रेसेस नीचे जाके बेसल बोन में जा रहे हैं. सो जो बेसल बोन जा रही है वो रिजॉल्व नहीं होती, वो हायर कॉर्टिकल बोन है.
Got it. Understood.
So
So it's
the
better
hue
to
and
use
cry
platform
world,
switch.
yes, the hue and cry world over is about the connections and about platform switch. The connections अब जो आते हैं वो most है, पर conical connections आते हैं. Earlier internal hex होता था या external hex होता था. तो external hex में जो हमारी connections होते थे उसमें ये crystal bone loss होता ही होता था. So everything has with time changed to avoid this crystal bone loss.
Right. Understood, sir. Thank you so much, sir. Thank you for patiently clearing the doubts. And so before we end, I want to present a small presentation about Dentist Channel for our viewers.
Yeah, sure.
And also our viewers may know that the link to the workshop has been put in the chat box. You can all just go ahead and click on it and see the entire details for the workshop. DentistChannel.Online. We are the first digital dental media in the country, and we stand strong with our motto, healthy smiles, wealthy lives. We offer multiple services for dental professionals, dental students, dental organizations, and dental businesses as well. You're most welcome to visit our website www.DentistChannel.Online for each of the services that we offer. We have conducted over 700 plus live dental webinars and have issued 40,000 beyond participation certificates. We have conducted nearly 30 dental workshops and have been blessed to host 400 plus national and international speakers. We have 300 oral care videos under Save the Tooth campaign. We have also made our way to India Book of World Records for maximum speaker participation in any virtual dental program on oral implantology. This is a sample of the certificate that we offer to our Prime members, and each certificate contains one CPD point, which is a German credit point. We invite you for our upcoming webinars with Dr. Sanjay Asnani and Dr. Disha Gupta, and of course, the very awaited our workshop with Dr. Parminder Singh Grover on the 5th of March. You're most welcome to engage with us on Facebook, Twitter, Instagram, LinkedIn, YouTube, WhatsApp, and Telegram. Thank you so much for your patient listening. We really look forward to more of such engagements with you. Thank you so much, sir, once again. It was indeed a pleasure to have you with us, and I'm definitely looking forward for the workshop.
Thank you so much. I'm also looking forward to it.
Thank you, sir. Good day. Thank you.
Good day. Bye.
Bye.